So again, good morning to everyone. My name is Sarah Vitse Doyle. I'm a clinical assistant professor here at ASU, and I'm very excited to be moderating this event. As a medical social worker myself, obviously I hold a special place to the practice that is medical social work. So I'm excited to have 4 medical panelists here with us, and I'll introduce them briefly in a moment. But our panel today is entitled Medical Social Work Practice and Contemporary Priorities in Healthcare, which I think fits perfectly well in the School of Social Work celebration of Social Work Month. So happy Social Work Month to all the social workers who are joining us. This year, our theme is entitled The Time is Right for Social Workers. And I think this really fits well into medical social work and also where we are seeing medical social work going and the changes that we are experiencing. So appropriately so, our panel is entitled Contemporary Priorities. So I'm trying to hone in on some of those ideas too. This is a career panel for those who are interested in the field of medical social work. So I open the comments box to any questions that you may have. I thought how we would start is just kind of an introduction of our 4 panelists, kind of hearing about their day-to-day and their roles and how they started in medical social work. And then I would kind of open it up to you all, because we're here to support you and your interests, and to see if there's any questions. So again, feel free to add questions in the comment box. I'll try to moderate it the best I can, or simply raise your hand if you feel like that's easier. If I can't see you all as I navigate the Zoom room, which I sometimes do not so successfully, please feel free to just unmute yourself and ask away if there's a moment of pause. Our housekeeping items today, I should just say, as I said, unmute yourself. I kindly ask that everybody does mute themselves. We're all familiar with the Zoom etiquette, but it's kind of a nice reminder. So if you'd please just mute yourself so we don't get feedback or hear what's going on in the background. Pamela, if you joined us a little while ago, I need to be respectful of our panelists and their time. It is their work day, and if they do need to step out or take a call, we completely appreciate that and understand that that might be appropriately so. Also, as you might have heard me say, this session is recorded, and the School of Social Work is planning to share it with those who couldn't join us specifically for the next hour. So I'm thoughtful to those who don't feel comfortable having their name shared or their face, their image shared publicly. I ask that you mute yourself and take your name off as well. And either April or I can support you in kind of, so if you don't feel comfortable being recorded, having your name appear, just message either April or myself and we can make sure to accommodate those needs. Great. All right, so let's get started. One more person to admit, which is fabulous. We have so much interest. So with us today, we have Jodi Mincemoyer. She is a social work team lead at the Mayo Clinic. We have Jenifer Riggins. She's the interim manager with Phoenix Children's Hospital. And we have Pamela Ruzi. Pamela, did I pronounce it correctly?
It's Ruzi.
Ruzi. Pamela Ruzi, and she's a pediatric social worker with Hospice of the Valley and Ryan House. And lastly, we have Eileen Delaney, who's a clinical care manager with Mercy Care. So I will kind of start by simply identifying that we were thoughtful in choosing our panelists simply because medical social work is such a broad perspective. I wanted to be thoughtful that medical social work isn't just represented in an inpatient setting. So a lot of these panelists also work in outpatient clinics or serve those in the community. So I want to begin by simply just asking all our panelists to talk to us a little bit about your current role and some of your general responsibilities of your role. So Jodi, do you mind sharing first?
Yes, hi there. Thank you so much for including us in this. I know there are so many social workers out there doing just amazing work, and I'm happy to be here to talk about transplant, but also about my role at the Mayo Clinic. I actually got started in medical social work with my graduate program. So my clinical year, what we called our clinical year, the second year of the program, I had a placement at our hospital. And because of my interest actually in macro work, I came from a background of kind of research and policy work. I was put with a social worker who was doing research and but I also had the benefit of being with this person who not only was she macro focused, she was also very clinical. And so I got to see just firsthand, that full range from the very clinical kind of work through the research and publishing that she was doing. And I was hooked. I was absolutely hooked. And then, of course, as I graduated, I was able to get a job there. It was not the best paying job in Richmond, Virginia, where I lived at the time. And it wasn't even the second best paying job in the area. But, I was able to get in there. There were lots of great medical specialties, and I was able to explore all of them. So I was working in bone marrow transplant. I was working, it was a level 1 trauma center. So I got to see crisis work, trauma surgery, all kinds of just really great situations where patients ended up. And then from there, I was able to kind of move into transplant, and I never looked back. I've been in transplant now for 11 years.
Thanks, Jodi. And another person who finds transplant their home will now transition to Jenifer Riggins.
Hi, so kind of my journey through medical social work was actually returning to school. I went back when I was 27 and told the advisor, I don't know what I need to do, but here's my credits and put me in a FAST program. And then they said social work, and I was like, I don't know what that is, cool. And I went to my first class, and it was like that Oprah aha moment. I remember the instructor, I remember the chair I was sitting in, the room I was sitting in, and I knew that this was my journey. I knew this was organic for me, and being able to be of service to people in a clinical way was exactly where I was supposed to be. So I finished all the programs pretty quickly. Went into fire and crisis initially, and then into medical social work in my last internship at Valley Wise, where I fell in love and realized that my population is the nitty gritty, the inner city. So once I finally transitioned over here to PCH, it's very different in a lot of ways and very similar in a lot of ways. So it kind of melted my heart altogether, because I have a particular interest in healthcare, chronic illness, and learning how to manage that and navigate it. And so I said yes to transplant after 4 months of courting. It's a very big relationship. And now I'm married to it. I started the program here at PCH for the psychosocial within transplant. I've had the joy of working with Jodi, actually, Eileen, I love all you guys on here, Sarah. But being able to build the program from the ground up, I started it for kidney, liver, and heart. As the program has grown, we have accumulated two other social workers to help support the program. But it is really walking through the journey with families and the patients, and being able to see them from their darkest moments when they're waiting to find out if their child's going to live or die, and being able to walk that journey either through grief or through life-saving and chronic illness, and being able to address the needs along the continuum as we follow the patients up into adulthood. So that is why I'm here. I'm also at St. Joe's in case management still, because again, I like the many things. And that's why I'm interim manager too. Sarah knows, it's a very busy life these days.
It's a little bit par for the course. Social workers like to be busy, right? We like our hands to be in things. Great.
Thank you.
Pamela, welcome, Jenifer. Pamela, tell us a little bit about your work.
So I actually, am I not on camera?
You are.
Okay, because I don't see myself. I actually started back in New York City as an art therapist. I have a master's degree in art therapy, and I worked in a child life department. And I'm going to share with all of you that I too, at that time, many years ago, was doing art therapy with liver and kidney transplant patients, which back then it was a fairly new thing because I've already been out here in Arizona for 28 years. So I moved to Arizona. I had an incredibly difficult time finding a job as an art therapist and went back to ASU to get my master's in social work. And always working in the medical setting felt right for me. So I was able to get a job at Hospice of the Valley, and 22 years later, I'm still there. I find what I do incredibly emotionally taxing, but it's also emotionally satisfying. People ask me, how do you work with dying children? And I tell them the day that I don't care and the day that I don't have a sleepless night is the day that I will walk away.
Real commitment to your work, Pamela. Great.
We all have commitments, and I think that we all eventually find our comfort zones and our niches. I think all of us would probably say that there's populations that we would not be able to work with.
Absolutely.
But thank you for also including me in this panel.
We're excited to have you. Thank you for joining us. And we'll round up with Eileen. Eileen, tell us a little bit about your role.
And thank you for having me, Sarah. I appreciate it. I work for an insurance company. I work for Aetna's Medicaid plan here in Arizona called Mercy Care. I've not always worked in insurance. I started out doing medical social work and kind of got into it through my internship. My master's level internship through ASU was actually with what's now Honor Health, but Scottsdale Healthcare at the time. I worked at the Shea Hospital, did my internship, still wasn't really sold on it. Went back to behavioral health. That was originally my home after I finished my BSW. Initially, again, went back to behavioral health. About a year later, found my way back to the hospital, was just kind of doing it part-time. And then I covered for a week for a full-timer that was off up on the trauma unit, and I was hooked. That was it for me. And so for the next almost 6 years, did level 1 trauma. I loved the chaos of it. I was in my 20s. It was amazing. We worked with awesome staff. It was always something, always. And it was, I mean, some of the best times, I think, of my entire career were working there. And from then on, I was hooked into the medical side of things. About 5-6 years ago, I found my way to the insurance world because I wanted to work at home. As you can see, I am in my home. I have always worked from home. It's a work at home position. There is room for social workers in insurance, and I think that it's something that is often overlooked. So I'm a clinical care manager. I help to provide care coordination and support on an outpatient basis to anybody who is Medicaid eligible with Mercy Care. That population looks like people with just Medicaid access. That looks like people who have REBA services and for the regional behavioral health provider, because Mercy Care has the REBA now. And that also looks like people with developmental disabilities. Mercy Care now provides DDD insurance support for the entire state. And so that's what I do, and my whole job is telephonic now.
You were working from home before it was cool to work from home.
Absolutely. I tell people that all the time.
Well, something that sticks out to me, since the interest of this panel is for our ASU students who are interested in this career path. And I think you all gave an interesting perspective that your practice evolves, your interest evolved. So to those students who are on this call and are listening and are kind of searching for what they're interested in, it's nice to hear our panelists kind of talk about their evolution and how they found it. So I hope you all kind of embrace that evolution too, and that space of, well, I don't quite know, because you're hearing from seasoned professionals that they didn't quite know either at one point. And here they are kind of continuing down this road, trying this, looking at this, and finding ultimately what felt right. And there was that aha moment. You know, Jenifer talked about one, Eileen talked about one, an aha moment where now this is where they want to be and sometimes where they need to be, right? I want to talk now a little bit about your day-to-day activities, because again, we're a career panel. We want to hear the nuts and bolts. So I would like to ask each panelist to just talk about your typical day and what that can look like. I know that can involve many different hats, but just maybe highlight a few for us that stick out to you. Jodi, do you want to begin?
Sure, thanks. So I'm in outpatient transplant, and there are 26 staff. I think, well, if we were fully staffed, we'd have 26. There are 26 positions. So as their team lead, I have to, keep an eye on staffing and scheduling. Our work is driven on a day-to-day basis by an actual schedule where patients are, they show up for some kind of an assessment or a supportive visit. We also run support groups. And so in addition to being team lead, I'm also, I have a caseload. So my role right now is as a post-kidney transplant social worker. And that means that I'm in clinic 2 days a week. I also am partnering with someone else who's in clinic on our busier days, 3 days a week. And then we have lots of meetings. We have selection conference and rounds and some complex care case conferences, just lots of meetings. And in transplant, we also have some, a lot of our day is guided, or not really our day, but our months are guided by the CMS requirements. So we have to have a quality committee, and we have to do departmental reviews if there's some sort of an outcome that isn't what we would have expected. So we're doing lots of that throughout our month. And there's so much more. There's also inpatient, so transplant, of course, involves a surgery. So we have an inpatient role, but we have our inpatient team runs interference really on those issues. And I will point out, while I am doing essentially at least 1.5 full-time jobs, it's very important to me to set boundaries. So any of the students who've worked with me know that my day starts at 8 and my day ends at 5. Ideally, there's a lot of days where I'm, logging on, especially when I'm working from home, I'm logging on earlier. But I really try to stick to that because I do have a life and I value self-care. And the things that I do outside of work, I really want them to be restorative. So I have, I do volunteer with the Transplant Community Alliance. I've been facilitating that support group for going on a year now. And that's 1 hour a week, except for the week that Banner does it. Sorry, my Banner colleagues aren't here today, but so I'll stop there. There's plenty more to talk about, but I know I want to hear from our other panelists as well.
Thanks, Jodi. Jenifer, want to share a little bit about your day-to-day?
Sure. So I ditto quite a bit of what Jodi said in regards to the transplant components of it. Here at PCH, we actually follow our families inpatient and outpatient. So anytime they're admitted to the hospital, we see them, assess them, see how they're coping, if there's any clinical interventions that we can provide at the bedside. And then when they're outpatient, we're assessing them on a specific frequency, also looking at those pieces. We assess pieces of the development, behavioral pieces, going along, just making sure that we're not missing anything as the kiddos get older. And then once they hit those teen years, we actually do a lot of work in the teen to adult transition piece, preparing them to go over to Jodi in the adult world. So as we know, that looks significantly different. So we really try to saturate our kiddos with that. From a management perspective, that's another hat. I clearly don't have boundaries like Jodi. I need to spend more time with her. So on the management side, I manage a staff of about 88 social workers, doing coaching and mentoring, providing opportunities for them to have training, collaborating with the community, with Sarah, our fellowship program here at PCH, between ASU and PCH. So a lot of those program development components, and that just mirrors over in my social or in my supervisor hat as well. So fabulous time.
Well, again, we all evolve, and you identify that boundaries are something you want to work on, but so great. Thanks, Jen, for sharing a little bit. Pamela, tell us about your day-to-day.
I'm going to echo Jodi in boundaries because I think they are incredibly important, especially with hospice. I'm walking into people's homes. I am walking into a home at one of the most emotional, personal, scary times of a parent's life because their child is either on hospice care, or something I didn't talk about is we have a very big palliative care program. Palliative care, they're not quite at end of life. They know that they have a child with complex medical needs, but they want to continue to pursue treatment. So my day isn't ever planned out. It changes from day to day. I could have 3 visits planned, and I can have a parent call and cancel because the palliative care parent may be going to the hospital, or I could all of a sudden have a child who's at end of life and they really need some social emotional support. So I may switch my schedule around for that. I joke with people when they ask me where my office is, it's my car. My car has everything in it. Most people don't carry DNRs, do not resuscitates in their car. I do, because I may have to at any time have a parent sign one. So I do assessing every day. I provide emotional support every day, and my day is constantly changing. I think it was Jodi who also talked about self-care. I am a huge, huge believer in self-care. I don't believe that we can continue to do this work if we don't take care of ourselves. I could go on and talk about how my days change and things that I do. And if anybody does have questions about palliative care versus hospice care, I'm more than happy to answer.
Great. Great. Well, this is all really great advice for students who are wanting to enter our field. So thank you for sharing. Eileen, tell us a little bit about what your day-to-day looks like.
Well, my day-to-day is probably slightly different because I, again, never leave my house. This is a job that actually has very good work-life balance. There are always issues with, at some point I have to turn my phone off, and it's super autonomous. And so I could keep the phone on later. I could answer calls on the weekend. It's really about where I choose to draw my boundaries. So my day is really driven by my clients, and in the insurance world, we refer to them as our members. And so I carry a caseload of about 45 at any given time. I do not work long-term care. I work in the acute side of the health plan. So I will keep cases open usually between 6 months to a year and then close them out. And it's referral driven. So we can get referrals for care management at the health plan from hospital professionals. We can get them from doctor's offices. We can get them from our utilization management staff. And those are the nurses and the social workers actually do a lot of utilization management, which I think a lot of people don't know. But they may see that one of our members is overutilizing the insurance product. And what that means is they're overutilizing the hospital. Now, it's not all about saving money. It's also about helping the member. Why are they overutilizing the hospital? Is it an education issue? Do they not know how to manage their diabetes? Is it an issue with housing? Are they using it because they want to get out of the heat and that's why they're going to the hospital? Is it substance abuse? And so in that aspect, I have to utilize not just medical knowledge anymore, but all of the knowledge, everything I picked up in school, all of my experience to try to meet the needs of all these different types of members. And so it just, my day, it really depends on how much my phone rings. I contact all of my members at least monthly, although they usually call me more than that. And I try to meet their needs. A lot of that is interfacing with providers. A lot of our members struggle with communication with their medical providers, their behavioral health providers. And so we can pick up the phone, contact those providers. I do a lot of three-way calls with my members. That way I'm modeling, showing them how to work within the healthcare system so that then I can close their case and they can continue to do it on their own.
System navigation is something I think all four of these panelists do, right? Eileen, I think that's what you're really highlighting is the significance of system navigation for patient, clients, members, and all four of those panelists, I can definitely say, wear that hat as well. Oh, great. Well, now that we've gotten to know a little bit about our panelists, a little bit about their roles, a little bit about their day-to-day, I'm going to open up the comments for anyone who has questions. You know, the women who are joining us also kind of used a fair amount of jargon. So if you had some questions about kind of the medical terminology that they're using, please feel free to lean on us for that. So yeah, I open the comments, or if somebody wants to raise their hand, April, if you don't mind help monitoring if there's any hands raised, I'll open it up for questions.
We have a question in the chat.
Great.
It's for Eileen. Do you ever miss in-person direct practice?
You know, I think what I miss more than in-person practice with members and clients, patients, is I miss in-person communication with colleagues. I think that's sometimes what I miss the most, is not having, you know, I have a team and we are in contact over the phone, we are in contact over Zoom, but my boss is based in Fort Collins, Colorado. And since the pandemic hit, we no longer go for in-person meetings quarterly as a team at our office. And so I think that's what I miss most. Other than that, I mean, I often feel as though I am in the home with the patients that I talk to. I spend exorbitant amounts of time on the phone with them. And my goal at this point is not to be the boots on the ground community social worker in front of them. My goal is to hook them up to those services and hook them up to natural supports. And so that I see as more of my role and more of what I can do for them rather than do that direct in-person kind of boots on the ground work anymore.
Our next question is for Jenifer. Jenifer, what is the most difficult part of your job at Phoenix Children's?
Well, I think every social worker here would probably answer it differently because, our different practices, different personalities. For me, I think the most difficult part is working in a large organization and being able to advocate for our patients within different policies that we're upheld to either by the insurance or our own organization. And we've definitely taken a hard hit and shift with that with COVID and like visitor restrictions, for example, because these are kids and kids have siblings and kids have multiple parents, sometimes blended families. And we have such limitations on that we have to get really creative for our long-term patients to be able to keep their families connected while following all the rules. That's hard for me because I'm a rebel spirit and rules were made to be broken. So.
And I think, Jen, when you talk, lean a little closer to your mic because sometimes we get a little, thank you. And I think this is a great question. I think, so I'm going to open up this question to all our panelists because like Jenifer said, I think everyone can have a different answer to this. And we all have parts of our job that we're challenged by. Jodi, what do you see as the most difficult part of your job?
So for me, the difficult aspect tends to be the fact that we are practicing clinical social work in a host setting, right? So I've worked at 2 medical facilities, and the previous one was very much nurse run, nursing administrators, and this one is said to be doctor run, but I mean, doctors are very busy people. They aren't. They are leading, the charge, and they are setting the tone, but really on the ground, it's still people with administrative master's degrees who are running things. And so I feel like we are constantly trying to not prove ourselves, not prove our worth, because I think that our teams value us, but we're just constantly trying to show the depth of the work that we can do. And I spend hours putting together presentations for whether it's my transplant team, whether it's for, various audiences throughout the healthcare setting. And, then I still get kind of the idea that we're the taxi cab voucher people. And, that's, I think, what in this setting, I don't know that will ever go away. I definitely, I think we all have some successes and challenges on that level.
The depth of our skill set sometimes can be very misunderstood and misutilized, I think, is kind of to summarize what Jodi is saying. Pamela, tell us about kind of what do you identify as the hardest part, most difficult part of your job?
I think there are a few, definitely. Sometimes isolation, because I am in my car, I am driving around the county. I don't always have people, it's isolation. I have tried to work that out to make sure that the nurse and I that I work with, that we do a lot of joint visits together, because it helps. And then we can talk about them after. There are only 2 of us in the PEDS world, 2 social workers. One covers East Valley, one covers West Valley. So we try very hard to connect and get together and talk about difficult cases. We do get together every other week to talk about our hospice kids as a team, but we don't always talk about our palliative care caseload. So the isolation at times can be, I think, challenging. I also, working with families who have children who are dying, it's emotionally challenging. Over the years, I've been doing it for a very, very long time. I, again, have found that self-care and that really fine gray line of boundaries is important.
camaraderie to process. And I know that the School of Social Work really supports for our students and want to drive home the importance of supervision and having mentors and people
Yes.
to go to learn from, to grow from, especially when you're a new clinician, a new practicing social worker. Having that camaraderie piece can be also very cathartic, right?
Absolutely. You put it very eloquently.
Eileen, tell us a little bit about what you find most difficult.
Just to piggyback a little bit on what Pamela says, I work autonomously. And like I said, I have a team, but my day-to-day is completely dictated by me and my schedule. And I have to have a lot of self-motivation. I usually don't find that to be the hardest part of my day, but it certainly, can be a challenge. And I do miss that connection with other professionals. What I can say that probably challenges me the most is feeling like I'm not doing enough. I feel like there is a lack of resources available here in the state of Arizona. There's what I feel like is a huge housing crisis. I bet of my 45 people sitting on my caseload right now, I bet a third are homeless and experiencing homelessness. And, we can think we have all these great resources sitting there, but sometimes they can't get in the door. And I can't do anything about it. I want to go out there and pick them up on the street and take them somewhere and help them access these services that are available, but sometimes it's just not enough. And sometimes it's hard to find community supports or natural supports who can help somebody do housing applications. Everything's online now. You can't get anybody on the phone if you call down to the housing authority. So I think it's a very challenging part of my job is accessing the resources that I'm trying to plug people into. It doesn't matter how knowledgeable you are if the resource isn't there or isn't there as it should be to really connect your people to.
Eileen, you touched on too why this panel is called Medical Social Work Practice and Contemporary Priorities. Because we as medical social workers are thoughtful of, yes, we have this medical understanding, this medical knowledge, and we look at disease process, but we have other community priorities that really would significantly help our clients if we had access to them. Right.
Mm-hmm.
I see Rosie has her hand up. Rosie, do you want to unmute yourself and have a question for our panelists?
Hey, good morning. I think
so. Just a little louder, please.
Can you hear me?
Yes.
Okay, thank you guys for sharing your experience. It's awesome to hear. I do have a question though. So I have experience working in the skilled nursing facilities part, a little bit similar, I think, but I think with the skilled nursing experience, I feel like it's insurance focused versus patient focused. So I'm wondering if you guys feel in your experience that it's the same way for hospitals or, just in general, your experience.
Great. So just make sure I heard that question. Eileen, hand up. I heard that question right. In your current role, you're kind of experiencing where it's an insurance-driven approach as opposed to a patient-centered approach. Are those practices that we see within the settings when we practice within? Eileen, you want to tackle that one?
Yes, and you're 1,000 times yes, you're correct in your assessment. A lot of healthcare is 100% insurance driven at this point. I think, and I explain to my members all the time, the way insurance works is not meant to be punitive. It's not meant to be mean to people. Insurance coverage is driven by what we call medical necessity. Medical necessity is something that even as a social worker, you still have to keep in mind all the time if you're going to work in healthcare. The way insurance authorizes things is from clinical criteria that's received from providers. Doctors at the facility have to send information that says this person has to remain here because of X, Y, and Z. If that information is not received, insurance doesn't know. They don't know. We can't see the patient. We have no idea. There's no global healthcare database where we can actually see that the patient has medical necessity to remain at a facility when, you know, the facility didn't send us that information. And so, yes, absolutely, a lot of discharge dates are driven by medical necessity and insurance. I have my members tell me all the time, hey, I was at rehab at the nursing facility, and then all of a sudden the next day they came in and kicked me out. That's always very much the perception. It's probably very much the reality. And so I do believe that a lot of times the social workers or the case managers at the nursing facilities are in a tough place, because then they're the messenger, and then they have to go in and say, hey, guess what? It's time to go. Let's order everything you need for a safe discharge. And the patient's going, well, wait a minute, like what did I do? I'm not ready. I'm not mentally ready. And so, yes, absolutely. It's just kind of the way that we have to function, I think, in medical social work, is we function under the umbrella of working in insurance.
Well, and if I can piggyback on that, and I'll open it up to our other panelists for their insights too and their practices. I think, to me, Rosie, what you're experiencing only identifies the significant need for social workers within medical settings. Yes, as Eileen talked about, the world we have, the system that we have for health insurance and medical treatment in our country is based on the medical model. And we are forced, our hands are forced to practice within that. And that's why we need medical social workers to navigate, support, encourage, interpret, advocate for our patients because of the systemic system that's been created around healthcare in our country. Pamela, Jenifer, Jodi, anything you kind of wanted to add about insurance-driven as opposed to patient-driven care?
Sure. I think I'll speak from two different hats. So St. Joseph's Hospital, that's where I do more case management and social work. Part of the ways that we can help support that is by meeting with families, not just the ones who are discharging, but being able to meet with all families that we're able to, and helping them anticipate the needs before it becomes the need. So if we are, meeting with our multidisciplinary team and we anticipate they're going home with equipment, or we anticipate they're going to skilled nursing, starting that conversation in the beginning so that it's not a surprise when the time comes, right? So giving them choices ahead of time, talking to them about how to go look at these facilities that can make the best choice for their loved one, because obviously the patient can't go look at it. So I think that's a way to empower families and help support their self-determination, is being able to do that. On the pediatric side, we're a little more privileged in respect to that, because it is PCH's mission for the safety and well-being of children. So if we anticipate that there is a social concern at home or they can't meet the need, we can hold patients here under a social admin. Will the insurance pay? Not quite sure. And as a PCH mission, we'll deal with that on the back end, because we want to assure safety before they go home. So it's a little bit of a different hat change in practice from weekends to weekdays. And I really stand behind that here at PCH, of making sure that the needs are met. Again, that doesn't mean that we hold everybody and they just live here, because we need beds for new patients. So it is still working towards discharge. It is explaining those pieces, but it's helping the family navigate it. So if it is fear, maybe they don't understand care, then we saturate them in education and knowledge, and we help them by, nesting and practicing and facilitating the home environment before they discharge, and ultimately empowering them to care for their child, to advocate for their child.
I'll just speak briefly. There's this sense in the community that Mayo doesn't accept Medicare or Medicaid. Not true at all. And just like every other hospital, especially every other transplant center, we are majority Medicare funded. However, I do want to just give you kind of a different perspective on the role of social work. So there is a social worker at Banner. He's a liver transplant social worker, Charlie Thomas. He's been around, I don't even know how long, certainly long before I moved to Phoenix. And back in the 90s, that's it gives you a glimpse of how long he's been around. He worked with a group of people to get access to covered transplant. So back then, Medicaid, people who had Medicaid in Arizona could not get transplants. So that is, and you know, this group got together, and now, you know, I don't know our numbers, but we certainly transplant a lot of people with access. And it's hard to believe that there was ever a time that that kind of limitation existed for patients. But so that shows you how, you know, you can be active at the ground level with, you know, doing the clinical work with your patients, but also working on advocacy at the same time.
Great question, Rosie. Thanks for your question. I think I will also kind of just add. Oh, Pamela,
Can
go
I
ahead,
just
please.
chime in real quick? Because insurance is definitely very interesting in the hospice world. It is different for the adult hospice than it is for the pediatric hospice. There's something called the Concurrent Care Act, which means that a child who is hospice for end of life can still seek certain treatments. In the adult world, you cannot do that. There's other small things for nutrition. Kids, pediatrics being on hospice care can still have TPN, artificial nutrition, and still be on hospice care. Insurance will still pay for that. There's the 6 months, which we do look at for pediatrics as far as hospice care goes, but there's a little bit of a wiggle room there. And then our pediatric palliative care program is actually a free program. So it is not insurance driven.
Great question, Rosie. I was scanning through the comments too, and it looks like a lot of other students had that question as well. So great. I think our panelists make some really great points of advocacy, the importance of advocacy and promoting change within the healthcare system, as well as we are seeing, Jenifer highlighted that we're seeing organizations within themselves kind of stepping up and supporting patients to the best of their ability, and kind of flipping the script a little bit on that and seeing the patient first. So I bring that back around simply as all of you I know are interested in this field and looking for a career in searching organizations. So that might be something you inquire with while you're interviewing. You know, what is your approach if this happens? Or I've had this experience in the past. How would your organization handle it? Or what resources would be available? Great. It's hard to believe we have 10 minutes left in our hour. So I'm trying to be thoughtful of the questions. We have a lot of students really interested in if your organizations offer opportunities for BSW students, MSW students, and opportunities for LCSW for clinical hour work. So I'll just go through the panelists and just ask. This is going to be kind of a two-part question because it kind of looks like to me, one, students are asking that, what availability or opportunities are there for them, as well as what, as a new medical social worker, what tools should students utilize to increase their opportunities to get within the medical realm? Do we want to start? Let's go backwards. Eileen, you want to start first? So to repeat,
I was just writing down some thoughts. I got to think about this for a minute.
we did expect to go. We were going through the list usually last, so I threw you off.
I know.
So does Mercy Care have opportunity for PSW, MSW, and clinical licensure?
Yes. As a new social worker, I would not necessarily walk right in and try to work for an insurance company, especially in a work at home position. I would say at least in your first 5 years, go be boots on the ground, get face to face with your clients. You can learn all the theory in the world and perspectives and therapeutic techniques in the books, but you don't know until you are really boots on the ground trying to work with members and patients, clients, go into the community. That is what I would say. I am not aware that Mercy Care accepts interns. In order to be a social worker and work for us, you do have to have a license and an LMSW. So that would be my recommendation. One area that I has kind of opened my eyes to in my work with substance abuse patients that I feel like is often overlooked when it comes to internships and jobs is substance abuse residential treatment. I think it's often overlooked. They're usually looking for people, looking at residential facilities like that for possibly getting therapy hours, that they need counselors. Mm-hmm. They're working with individuals with behavioral health, usually dual diagnosis, behavioral health and substance abuse. So I would definitely recommend thinking outside the box as far as getting hours and things like that.
Great. Thank you. Pamela?
We are not considered a clinical setting. Why? I have never understood. I think the state needs to rethink that. So no, you cannot get your LCSW, hence why my 22 years I've remained an LMSW. We do take, I don't know the answer to BSW. I think we do take bachelors and they have worked in some of the inpatient units, but I honestly cannot give you an answer for that. And what else was I supposed to answer?
Advice to any advice for to a new medical social worker wanting to enter the field?
I think you should go for it. I would agree definitely that you need to have your boots on the ground. You need to be in a setting where you definitely are around other people. You're learning, you have the supervision, you have the colleagues that you can talk to. I think as I was scanning through some of the questions, people were asking, do you have to have medical knowledge? You really don't. I think you learn it. I think you get supervision, and I think it comes to you and you learn. Granted, I have been in the medical setting for so long, but I learned a lot also, and I still learn a lot. So I don't think it's something that you definitely have to know everything about.
Great insights. Thanks, Pamela. Jenifer?
So as for BSWs, we actually don't take them within our department. However, there are plenty of positions here in the hospital that you can be a BSW while working on your MSW, like BHTs and things like that, which we do offer. I think I saw a question in there of work variance. So that is an opportunity that individuals can do. The only requirement is that you are interning outside of your current department, because we're wanting students to get a unique experience. As for working here, you have to be a licensed master social worker, and there are clinical opportunities. We created a clinical ladder here over the past few years where you can participate in one-on-one psychotherapy, inpatient psychiatry groups, all of those pieces to be able to work towards clinical licensure. And we've had a few individuals actually complete that and pass through the board, which has not been historically common in Arizona, getting your clinical hours in the medical setting. So it's definitely a shift that has occurred and is working and elevating our profession within medical settings. I think for tools and working in the medical field, we are, at least here at PCH, we actually encourage students to go work in the community. Again, it's the boots on the ground idea. Even if you want medical, go to a hospital that has probably a little less resources than somewhere like PCH, because that forces you to be creative. It forces you to problem solve and really learn social work and be able to help empower families. You know, people donate to the Children's Hospital. We are able to provide assistance, but we also don't want to disable families. We want to empower them and uplift them. So that's usually our recommendation with it, is come here after you've already kind of worked in the trenches.
All right.
Jodi, I know you put yours in the comments section for for everyone, but if you don't mind just kind of reiterating.
Sure,
opportunities at
yes.
Mayo.
I am not aware of any BSW internship opportunities here. We do have internship opportunities for students in their second year of the master's program, and we have 6 slots we're interviewing right now for the next academic year. So that's always exciting. I am core faculty with that program. I do really enjoy I really enjoyed this panel, but just a plug for what to do, how to kind of get yourself going in this field. I agree. It's really good to work on an inpatient unit and just to get to see like the flow of medical social work and how that goes, and then kind of graduate. That's how the way we do it here, to the outpatient setting. And when you get started in the field, I would encourage you to find good mentors. They're not necessarily the people sitting right next to you. And that is how I ended up getting in transplant. I had this mentor who was kind of tired of working in transplant, which sounds crazy now. And so she sort of helped me get the position, and I never looked back.
We have time for just one more quick question. I'm hoping it's quick. Kamisha, I hope if I'm pronouncing it right. I see your hand raised. Should we fill our last minute with your question?
So it's Kamisha. Kim works.
Excuse me.
It's okay. First, thank you all for taking the time. And I heard you all say boots on the ground. How would you suggest I go about moving from boots on the ground, which I've been doing for several years in several states, to more of a medical setting and more behind the scenes to deal with like insurance, social work, and working with the families to make sure they have what they need at hospice, end of life care, something in that direction.
I think I'll give a chance to answer too, and allow the panelists if they have any other additional insights. I know for many of us, specifically because so many of us on this panel I have met this way, started working in hourly per diem hospital work. So we kind of got our feet wet within healthcare settings through working at a hospital as a per diem person, filling in on weekends, holidays. Hospitals are 24-hour services, right? So that would definitely be, it's sounding like you have some experience as a boots on the ground, a community social worker, and if you're wanting to now move into healthcare, that would definitely be an opportunity, I think, and hospitals are always looking for per diem staff. Anyone else have anything to add to that, advice to that?
I do, yeah, it's Eileen. So just real quick, I'll be brief. So one thing definitely that I'm sure everybody is seeing as kind of a theme, the hospital settings generally want you to have your master's degree to work like as a unit social worker, and they want you to be licensed. I do actually have 2 people on my team who are unlicensed, and they have a different job title, and they work with our supportive members who don't have as high of needs as our intensive members do with the insurance plan. Just a general background, a lot of them have the general background of working in the behavioral health clinics, and that was kind of their entry into the position. I know several of the large insurance companies are hiring. Everybody wants to hire right now. There's a lot of open positions. So if you're just looking to get your foot in the door somewhere, maybe you're interested in medical work, maybe you're interested in insurance, peruse some of the large insurance companies' websites. All Medicaid plans are actually underwritten by large private insurance companies here in Arizona. And so check out their websites. Don't sleep on that, because you can actually start to get your foot in the door a little bit more if you already have a lot of that boots on the ground experience that way.
And I do have to apologize. I know we had such wonderful participation. I am so grateful to our panelists. I think I hope we gave you all a really great perspective on the variety of medical social work, gave you some insight into what our work looks like. I put my email in the chat for ASU. So you're welcome to reach out to me. I meet very frequently with students who are interested in medical social work and just need advice about it. I also, part of my role for the university is working with our field office. And so I have some acting knowledge of our current internships that ASU offers. So if you'd like to email me and talk to me about what internships might be available within Phoenix and Tucson. I know there was a comment about not just Phoenix area. Please feel free to reach out to me directly, and we can schedule some time and talk about your interests and how ASU can push you forward in the medical realm. Again, a deep gratitude to our panelists and the work they do and their commitment to medical social work. I'm honored that they participated today, and I will close in just wishing everybody a very happy social work month. And I hope to see some of your faces in the medical social work field shortly. Thank you, everybody. Enjoy the rest of your Friday.